there.
Jacques, absolutely. Good afternoon, everyone. Let me begin by thanking the organizers for inviting me to give this very brief talk. And I'm going to continue the journey by focusing on the domestic HIV epidemic in the United States. And I'm going to focus on a particular subgroup, men who have sex with men who are experiencing hyperendemic levels of HIV in the United States. And the purpose of my talk today is to think about the role of implementation science in optimizing our response to the epidemic in the United States. So I'm going to begin by just briefly reviewing the epidemiology of HIV and STIs among men who have sex with men in the US before moving on to our new strategic framework for really thinking about opportunities for addressing these epidemics within the United States. And then finally, I'm going to reflect on implementation science and some of the research questions which pertain to our work with men who have sex with men in the United States. And I hope that as a result of this presentation, I'll be able to stimulate your thoughts in what can be done and what is the role of national public health agencies. And that's the unique perspective I'm bringing this afternoon to addressing implementation science, both in the development and the delivery of our prevention programs. Okay, so let's just begin by doing a very brief overview of the US epidemic. Hopefully this is familiar to most of you in the room. As you know, there are more than 1.1 million Americans who are living with HIV, and the prevalence of HIV in the United States has been increasing consistently, certainly since the early 1990s. In the US, we also have stable HIV incidence. This has been stable since the late 1990s at about 56,000 new HIV infections each year. But the stable HIV incidence actually hides a lot of heterogeneity between the transmission risk groups. So for example, we've seen consistent declines in HIV incidence among injecting drug users since the mid-1990s. We're seeing increases in HIV incidence among men who have sex with men, and among heterosexuals, we're seeing relative stability in HIV incidence in the US. It's a very mixed picture across the transmission categories. So let's focus now on gay men, and what are we seeing in terms of HIV and STIs among this population? Well, unsurprisingly, and consistently with other Western industrialized countries, despite the fact that MSM account for about 2 to 4% of the adult male population in the United States, they account for a severe and disproportionate burden of HIV and STIs. We now estimate that gay men account for about 57% of new HIV infections which are occurring in the United States. And as I said earlier, they're the only group in which HIV incidence is increasing. Gay men are 44 times more likely to be HIV positive than other men in the United States. And this is a figure that really isn't reflected on in terms of the burden of disease among gay and bisexual men. We also see tremendous burden as well for the other STIs, and here I've just pulled out some of the data for syphilis and gonorrhea and HIV co-infections with STIs to really drive home the point that the patterns that we're seeing for HIV are also consistent. For syphilis, gay men account for about 62% of syphilis, primary and secondary syphilis cases in the United States, and this has increased dramatically since the early 2000s. We're seeing increases among gonorrhea in men who have sex with men, and consequently, the high HIV incidence combined with the increasing incidence of STIs means that we see a substantial proportion of men who are HIV co-infected with these sexually transmitted infections. In the US, we're also very concerned, and this is really consistent with colleagues working in Western Europe, about the re-emergence of a variety of other sexually transmitted infections, including epidemics of HCV, LGV, and clearly high prevalence of HPV infections as well. So this really provides a sort of overview of the challenges that we're facing with the epidemiology of disease within the United States. And as an exemplar, I'm going to move into a little bit more depth into what's happening with HIV incidence and prevalence in the US. And I'm going to be discussing a few issues related to health equity as these epidemics are evolving. So this slide just really shows estimated new HIV infections by risk and race, ethnicity, and gender categories in the United States. And I've highlighted here how the 56,000 new infections are distributed across various groups in the US. And you can see that for men who have sex with men, they account for 3 of the top 4 categories, white MSM, black MSM, and Hispanics in the United States, and again confirming that burden of disease. One of the things we're really concerned about with the US epidemic among men who have sex with men is the increasing concentration of disease among young MSM, and among those young MSM, the tremendous health disparities that are now appearing. And these are data from our HIV incidence systems, which really suggest that among Black and Hispanic young MSM, we're seeing a high proportion of new HIV infections occurring in those groups. So if you focus on the middle group of bars there, you see among Black men who have sex with men, more than 50% of new HIV infections are occurring in the 13 to 29-year-old age group. A very similar distribution or pattern is seen among Hispanics, where young Hispanic MSM are bearing the brunt of new HIV infections. Finally, just to drive this home, the high HIV incidence is really driving unprecedented prevalences among men who have sex with men in urban centers within the United States. These are data taken from 21 cities from our national HIV behavioral surveillance system. And the table may not be very clear, so I'm going to walk you through some key data points on the table. These are data looking at MSM aged 18 to 29 years. The overall prevalence of HIV in the 21 cities was 12%, but most worryingly, 63% of those individuals were unaware of their HIV status. When we look at the distribution of HIV incidence and undiagnosed HIV by age group, we see the increasing prevalence of HIV with age, but also the high levels of undiagnosed HIV infection which exists whether you're 18 to 19, 20 to 24 years, or 25 to 29 years. And this really is in fact driving onward transmission within the population. The third thing just to highlight here is the disproportionate burden of HIV among Black MSM, despite whatever the age stratification. So among 18 to 19-year-old Black men who have sex with men, the prevalence is already 9% in the United States, with 71% of these men being unaware of their HIV infection. So this is just really to set a bit of context in terms of what we're seeing with the evolution of these epidemics within the United States. And clearly, the risk behaviors are also evolving as well. And you're very much aware of some of the changes which we're seeing in the US, which are consistent in other Western industrialized countries. Whether this is the increasing proportion of men who are reporting unprotected anal intercourse, the high prevalence of men who are using non-injecting drugs, which can facilitate transmission and acquisition of HIV and STIs. And clearly we're seeing other patterns which are changing in terms of men's risk behavior. And in these data from San Francisco, I just wanted to highlight the fact that we're seeing increasing proportion of men who are reporting serosorting. And that's of particular concern for us at CDC, as men are making their own decisions and choices regarding reducing their risks of acquiring HIV and STIs. And although serosorting may be lower risk for HIV transmission than practicing unprotected intercourse, it still results in some risk for acquiring HIV and certainly STIs. And so this is an area of concern for us. So I'm going to move now then from setting the scene to talking about what are we actually doing about this and how does implementation science help to guide the work that we're doing as a national public health agency. Well, we've been working on a new strategic framework for MSM, HIV and STD prevention and sexual health at the CDC, and this was released earlier this year. And the purpose of this new strategic framework is to guide our programs, our research, and our policies.
Oh, heaven.
I think you need to. Thank you. To facilitate our communication with partners and to really be able to better leverage the opportunities that we need to in terms of working across federal government when it comes to enhancing our prevention efforts. So in this new strategic plan, we're moving away from simply focusing on disease and really stepping back to think about a future in which we're working towards gay men having optimal health outcomes and an equal opportunity to achieve health free from stigma and discrimination. Now, our new strategic framework is based on 3 key pillars, and I believe that implementation science really cuts across all of these. First, we need to do a better job and a very different job of engaging both the community as well as leadership nationally on the crisis that we have with HIV among men who have sex with men in the United States. And one of our commitments within the strategy is to work proactively to build these new engagements and leadership with the community, whether this is through expanding community initiatives, thinking differently about our social marketing campaigns, engaging the community on some of the gray areas of prevention. For example, what do men and what should men be doing about serosorting in the 21st century, and of course looking at new media and social media as a way to engage the community in a very new way. Clearly, we need to be working on expanding effective and evidence-based prevention interventions, and this is the second commitment in the strategy, really thinking about bringing to scale the most effective interventions for men who have sex with men, but also thinking about ways in which we are doing studies to understand the best combination of interventions that need to be brought to scale. So whether this is expanding our HIV testing initiatives with men who have sex with men, scaling up our efforts to screen and link individuals for care through a syphilis elimination effort, looking at rigorously evaluating homegrown evaluations for HIV behavioral interventions for men who have sex with men, and changing the way we fund community-based organizations to do a better job of both assessing needs within the community and, of course, delivering the most effective interventions. Thirdly, in the strategy, we're really thinking about different ways in which we should be enhancing our evaluation, our monitoring, and our dissemination. Really thinking differently about the types of data that we need to better characterize both the epidemics within the United States as well as the drivers of the epidemics, so that we can do a better job of targeting. And some examples of our current activities are highlighted here: our new HIV incidence systems, surveillance systems, expanding CD4 and viral load monitoring, really looking at population-based estimates of men who have sex with men, expanding MSM behavioral surveillance using internet surveys and methodologies, and of course disseminating evidence and best promising interventions. So clearly what we're moving towards is again focusing on optimal health rather than simply focusing on STI prevention or HIV prevention. So I think this really takes us nicely into the third and final part of the presentation today, which is really to focus on implementation science. And how do we integrate implementation science in what we're trying to do in terms of enhancing our response to the MSM epidemics in the US? Now, clearly, the challenge that we have, whether it's for MSM or IDUs or heterosexuals in the United States, is a question of how do we bring together all these various interventions to prevent HIV risk and transmission, and how do you do it in the most optimal, effective, and cost-effective way? And things that are cutting across all of our prevention programs in the US are highlighted here. We really need to do a better job of improving the effectiveness, the quality, the impact, and sustainability of evidence-based prevention programs. We need to do a better job of improving the adaptation of interventions at the local level, whether it is within specific populations or in any given setting. We also need to do a better job of thinking about the capacity of community-based providers as well as clinical providers to be able to disseminate and to improve acceptability of our interventions. And as we've heard throughout the day, we need to do a better job of modeling the epidemics which are occurring in the United States for cost effectiveness and really looking at the potential impact both of new interventions, but also the ways in which we should combine these interventions most effectively. I think from MSM in the US, there are some specific implementation science questions which have arisen. We need to identify the most effective strategies for reaching high-risk men who have sex with men for HIV testing, as well as other prevention programs. And I think the new data from the IPREX study and the work that we're doing now on PrEP among men who have sex with men is really bringing this to the fore. We need to determine the best mix of approaches to link and retain newly diagnosed HIV-positive men who have sex with men into care and treatment. And again, this has been a recurring theme from the presentations today. And clearly in the United States, we have a tremendous problem with the prevention, treatment, and care cascade. And this cascade is, I would argue, perhaps even worse for men with MSM of color. Finally, I think we need to look at identifying the best approaches for increasing PrEP adherence and reducing sexual risk behaviors among high-risk HIV-negative men. And finally, discover ideal combinations of behavioral and biomedical and structural prevention interventions to maximally impact the HIV epidemic among MSM. There's some things that we're already doing at CDC in this regard, and I've highlighted a few here so that you're aware of some of the implementation science activities that we have ongoing. We've been looking at optimizing our HIV testing efforts, so not just scaling up HIV testing, but really looking at new methodologies for doing more testing faster and with greater impact. So for example, looking at studies to examine the effectiveness of different strategies for identifying and testing African American men who have sex with men, looking at alternative venues, social networks, and partner services. We're very interested in looking at ART adherence, and our compendium of effective interventions now identifies 8 effective behavioral interventions that can help to improve medication adherence. And the idea here is that our funded partners will be able to take these interventions and apply them locally. As many of you know, CDC has released interim guidance on PrEP, and that really has a very strong theme of implementation science running through everything we're doing. And we're collaborating both with the NIH and other partners to begin to think about demonstration projects that can provide real-world data as we think about optimizing implementation. And then finally, clearly, we're also committed to looking at combination prevention. And you've heard about some of our activities earlier today from Carl Diefenbach through our enhanced comprehensive HIV prevention program with 12 jurisdictions in the United States. And again, just to reinforce, this really is looking at ways in which we should be characterizing local epidemics much more effectively, looking at local capacities more effectively, combining interventions, and assessing the impact of those interventions in a very new way. I think there's some challenges to implementation science for MSM and prevention, HIV prevention. Some have already been mentioned by my colleagues today. First of all, we are challenged by the proportion of the MSM population who are maybe hard to reach, or who are failing to engage or re-engage in prevention. And there are a variety of reasons for this, whether it's discrimination or stigma, homophobia, and certainly racism. And clearly for a certain cohort of men who have sex with men, we are dealing with prevention fatigue and a decreased concern about HIV. And I think that's really complicating the work that we need to be doing. Another challenge is the need to address effectiveness, cost, and feasibility and scalability as we move to real-world implementation. And as a public health practitioner, I think sometimes the perfect can become the enemy of the good. And certainly the sense of urgency that we have in terms of scaling up our interventions, moving out into the field and making a difference may sometimes not be the best thing for thinking about implementation science in necessarily a thoughtful or in a linear way. So we need to find new ways in which we can both pair the implementation science and research with active program implementation and scale up. And then no talk would be complete without really reflecting on some of the fiscal constraints that I think are common not only to the United States, but certainly other Western industrialized countries, which really is challenging us to think about the ways in which we are doing our work, thinking critically about what our priorities are, and holding ourselves accountable for using the scarce resources as effectively as possible. So this brings me to the end of the talk. I really just wanted to take you to another location, to another place in time and another population to focus on the United States, what's happening with the domestic epidemic, to really illustrate the hyperendemic levels that we're dealing with among men who have sex with men and HIV in the United States, some of the new strategic directions that we're implementing at the CDC, but also to reflect on the role of implementation science and how that needs to be part and parcel of what we're doing as a public health agency moving forward. Thank you.